My name is Jane Gonzalez, and I'm part of the planning committee for this event. And I want to just let you know again how happy I am that we're all here together at this event, because it was really kind of sad that we had to suspend it for a few years until we all got recuperated from Ike. So we're back. I wanted to present to you Dr. Susan Garrick, who is got her bachelor's at UT in Austin. Hook 'em. And then she went to school here, medical school here in Galveston, and did her internship and residency in pediatrics here. So, she is a UTMB family member. She's professor at pediatrics at the here at UTMB in Galveston, and she's director of general pediatrics inpatient services and also children's special services at UTMB's Interprofessional Education Initiative. It's called Synergy, and she also co-directs the Practice of Medicine 1 course. So she is very qualified to know exactly what y'all are needing on the topic of challenges of managing special needs children. So hopefully we'll have a few minutes in the end. If y'all can have any questions, write them down. If not, you can write them on your evaluation, and we can see about answering those on the website. Thank you all.
Thank you. Thank you so much for the lovely introduction. I'm really honored to be here with you all today. There's so much enthusiasm, and the program is wonderful, so that makes me feel even better about being part of it. So thank you so much for joining me in this workshop. And how many of you all have cared for children with special needs? Okay, I'm talking to experts. That's wonderful, because really most of the time that we spend together today is going to be sharing wisdom with one another. Okay, so I'm going to go through a little bit of background information just to prime you so that we can handle 3 different sort of difficult cases together. And if you all have questions or comments along the way, you're welcome to ask them or make those comments. And certainly when we discuss the cases, I would strongly encourage you all to participate so that you can share ideas. And I have a wireless microphone. We can pass that around in the audience when it's time for you all to speak. All right, so our objective here for this next hour is to describe strategies in caring for special needs children in the school setting, okay? And really what I want to do is acknowledge you all as members of the healthcare team for these children, and talk a little bit about your role there, and then get your input on how you would handle some different situations. So first I'll just do a little bit of a background, as I said, to prime you all for our conversation. Then we're going to have 3 cases of children that are in the school system that have special needs and special situations in the context of their special needs, and see how you would handle them. And then we'll just have a brief summary and wrap up. And we should end on time so y'all get a little break. All right, so what are we talking about when we mention children with special needs or special health care needs? Really, those are children that have some sort of physical or mental, or both, conditions that interfere with their daily functioning, and those conditions last over time. Now, there's different numbers about how many of these children are out there, but we know the number is growing over time. Just reflect back 30, 50 years ago, before they had ventilators for little micro-preemies, those children just died. And now we're saving more and more children, and oftentimes they do survive but have some sort of chronic condition. So we have a decrease in the mortality rate of the micro-preemies, but then also with children that have devastating accidents or illnesses. And certainly, as you know, children don't stay in the hospital nearly as long, and we're able to support technology-dependent children in this home setting and in the school setting with much more frequency than we used to. So as I said, there's differing reports about the numbers of chronically ill or children with special health care needs out there, but as many as 1/3 of children have some sort of physical condition during their youth that lasts some duration of time. And 1 in 5 children have developmental delays and behavior problems, maybe emotional problems or learning disabilities, and those are the children that you'll definitely see in the school setting. And as you can see, as many as 6% of the children have really severe chronic illnesses for which they have to be under medical supervision consistently. So this is really important and near and dear to my heart, and I'm sure all of you all who have taken care of children with special needs appreciate the value of the team. It takes a lot of different people with different expertise and different perspectives to take care of children with special needs. And certainly if you're a school nurse, you see you're listed there amongst many others. And if you stop and think for a moment about some of the children that you've taken care of and some of the healthcare professionals and other community professionals that you've worked with, you know that their roles are invaluable in being able to serve the needs of those children. So what is our job as team members? And as I said, you all of you are team members if you're helping to care for a child with special needs. Well, we have to keep the family updated, and that means really good communication. We also have to know what's out there, what sorts of community resources, specialists are available to address the child's needs. We need to be available when it's important for us to do so, and we really need to be watching for not only exacerbations of the medical condition, but then also excessive stress for the child, for the parents, and for other caregivers that are involved, including ourselves. And also encourage respite intervals, again, for the child, for the parents, and for other healthcare providers, including ourselves. So how do we achieve these goals in the school setting? You know, that's kind of mighty, right? All of that. But the first thing that we have to do is really make a commitment to the child and make a commitment to the family and make a commitment to one another to work together and acknowledge one another's talents and abilities to help out. So it's really important that we apply compassion and empathy, that we appreciate their growth and development and our own, that we recognize immediately life-threatening conditions and chronic health problems as well, and overall to really promote wellness, optimal living, the highest standard of living, or the highest quality of life. We also want to continue to expand our knowledge, and you all are doing that here, and I know that you do it offline too as you go along on your daily routine. But we really want to focus on the scientific basis of medicine, and that's certainly not to the exclusion of things that we find on the internet, for example, but we can act as informed intermediaries for families and for patients if we are familiar with the scientific basis of medicine. Then also kind of being familiar with some of the diagnostic and therapeutic modalities, so we know the language that a family is talking, acknowledge those and respect those non-traditional modes of therapy that are available, and speak wisely and supportively to families about those, and then relieve pain. And in pain, I mean really in the global sense, psychological suffering in addition to physical pain. So, and then, you know, we're really at service to others. We're serving the children and the families and the school system at large and one another. So that takes teamwork, acknowledgement, and access to community resources, the evidence base that we talked about, assessing risk and making wise decisions based on that, and then, of course, lifelong learning. So we want to communicate with one another, respect one another, collaborate, and advocate for our patients and for the families. So the reason that I included this making decisions together is, again, you're an important member of the team, and as much of this process that you can be familiar with will help you be optimally familiar with the students that you're helping to serve, the patients that come into contact with you, and then you can communicate better and help make wise decisions. So generally what we see is a patient will come because something doesn't work right, or something doesn't look right, or something doesn't feel right. And sometimes we're able to make a diagnosis. Oftentimes we are. Sometimes we're not. How many of you all have encountered children that there's no diagnosis really? You just know something's wrong. Plenty of you all. That's not very gratifying, is it? Leaves a lot of question marks. So nonetheless, whatever you're dealt, if you know the diagnosis, at least get familiar with the condition and decide upon goals. Goals are really important for decision making. And then you consider all the different options, consult the resources, treat or refer, and follow up. And y'all are part of this process. If you're seeing people in the school system, then you're going to be familiar with where they are down this road. And knowing what the goals are is going to really, really help you be on the same team with the child and the family and the other providers. So you all are familiar with the Individuals with Disabilities Education Act, and that's what puts these children into the school system. Just briefly, I wanted to touch on the parents' experience because sometimes it becomes a them versus us kind of phenomenon, a little bit of judgment on both sides. Sometimes it can be overt anger, which really interferes with the care of the child. So I want us to acknowledge that the parent's experience of having a child with special health care needs is really an evolving experience, and oftentimes it's fraught with some adversity. And what does adversity mean? Well, it's different to every family. Sometimes it has to do with what's wrong with the child. Sometimes it has to do with how they view it. And you might see something is wrong with the child, and the family might view it as a gift. Have y'all heard of that before? So that's important to know. There is a sense of living with loss. Even if a child is surviving, even if they're not terminal, they may not be the child that the family was expecting. So there's grief involved there. Oftentimes, though, the family is resilient and they're able to gain strength. So what can we do to help families manage adversity? Help them get information, help them prepare, negotiate with them, have conversation and open communication, and make resources available to them. Oftentimes, families that have children with special health care needs normalize the situation. And what I mean by that is they just get used to it. Okay? And that might not mean that they like it or it's okay, but okay, so how many of you all can remember to take your multivitamin in the morning? Okay? So many of us forget that, right? Well, what about a child with a trach who's ventilator dependent and gastrostomy fed? You know, after a while, a trained family member will just go turn on the suction machine and suction the trach, and other people will gasp. And that's normal to the family. That's part of their life. So the chronic sorrow and the loss is, though, something that we need to acknowledge. Even if somebody appears to be coping really well, remember on birthdays and anniversaries and when they should have gone to the prom, all of those things can prompt grief. So, and speaking about grief, the death and dying is not specifically associated with the chronic loss that we're talking about, but I think it's helpful to have some insight into what a family is experiencing, and maybe even what we're experiencing on behalf of that child that we're caring for. A lot of us have a real problem with denial because they're so overwhelmed with pain because of something. So be careful about denial. It has its place. Bargaining sometimes drives people to drive you all nuts, right? Have y'all seen that? People think that if I can just achieve this, if I can just get this for my kid will be better off. Or at least it'll offset some of the guilt that I feel, the shame and blame that I feel because my child has a problem. Anger, how many of y'all seen that? Okay? So the anger is not about us, but a lot of times we're the recipients of the anger because we're there, okay? And if you have a great big heart and you're open wide, then you can be a recipient even more than other people can, right? Because you're safe to that family. It comes in a variety of forms. Sometimes the anger never goes away, and if we can just be present and not personalize it, then we can really be tremendous healers for families and children. So then the depression, the guilt, shame, blame, all of that, people feeling hopeless and helpless, and we can help with that too, right? We can shed some hope for them through our relationship that we build with the families. And then acceptance, and acceptance is sort of probably not the right word to use because oftentimes it really is just a matter of somebody kind of getting used to what they have, what life has dealt them. So, but nonetheless, the concept of possibilities lingers. probabilities, that lingers too. And we can help with that too. You know, the kindest thing that we can do is to continue to dish out hope. Okay? Not false hope, but just hope. And certainly we can dish out our presence. So another little thing about futility, how many of you all have cared for a student or a child who was terminally ill? Okay, so some of you have had that experience. And so you probably had some conversation, at least in your mind, if not with your colleagues, about futility. And these are some of the definitions of futility. You know, you give the treatment and it just doesn't work. Or they're probably never going to get out of the hospital. Or if they get out of the hospital, they're probably going to have a short life at home. Sometimes futility is really about quality of life, and that's where people really start getting nervous. You know, people have a hard time talking about futility around quality of life because all of us have a different definition of that. And then, of course, our sense about how dependent on high technology should a person be. So, and I'm bringing these up because they're really important for us to have in the forefront of our minds when we're caring for these children and we're dealing with these families, because whether or not we acknowledge it, those things impact the way that we interact with those individuals. Okay, the way that we make decisions, even the way our affect and our body language and our tone. All of those things manifest how we really feel. So we may as well just man up and acknowledge it and see how we feel and how the family feels and deal with those issues. So, and then the ethical issues, you know, that cuts across every profession. These are the primary ethical principles that we have to deal with each case that we encounter. So you all know autonomy is really about respecting people's decision-making ability. Beneficence is about doing good for people. Non-maleficence is about not doing harm. And then justice, fairness. So let's talk about Starla first. Starla is a 13-year-old girl, and she has spina bifida, and she's been absent from school a whole lot because she has recurrent urinary tract infections. She also has decubitus ulcers on her hip and her right ankle, and you're really worried about her physical condition, and you want to advocate for her. So how would you proceed in advocating for her? Okay, I'm just going to tell you a disclaimer up front. I've given you 5 choices. You might like all of them. You might like part of each of them. You might not like any of them, and you have your own idea about what to do, okay? It's meant to be that way. There's not necessarily one right or one wrong answer, okay? This is meant to make a rich discussion for us. So take a couple of minutes, speak with the people that are right adjacent to you, and kind of turn over which of these, if any, that you would choose to proceed with trying to help this young lady with spina bifida. Okay, would you call CPS because she's got decubiti? Would you call her mom? Would you call the doctor? Okay. How many of you all know Starla? Or somebody just like her? Yeah. Okay, well, I'd like to hear from you all on what your thoughts are. You say you have a patient like, or a student like that? Would you?
Yeah, now mine is not bedridden because she's up and about, so the decubitus ulcers on her hip and her ankle would not be an issue. But I talk to her mother all the time because she's self-catheterizing, and they have issues at home with her doing that. I don't at school, but they do at home, so it's an ongoing discussion with the mother. I can't imagine calling CPS or the physician because mother is real good about relaying my messages to the physician. My principal, I always let know what's going on, and I would think that the counselor, what good is that? You know, the thing with the 13-year-old girl and with my girl with the recurrent urinary tract infection, although I do not think this applies to her, but, you know, she's a 13-year-old girl, and there's a hanky-panky going on. So, I mean, I don't think that you can completely disavow that. You know, but with my kids, thank goodness it all worked very well. But to me, be the person that would be mom. Even if it's a telephone conference, it's still a conference with the moms.
That makes sense. Other thoughts?
Well, we were just saying you're probably not going to get a hold of the position. So you're certainly not going to get a conference, and so we're going to have to go around that through the parent probably.
We talked to the nurse. I think when we're talking about a school setting, you have to have the parental permission before you talk with the doctor.
Very good point. Very good point.
And I think the counselor could be a part of the teaching program. I mean, I feel that way.
I agree with the counselor. You're going to have some issues with the child coming out of the classroom setting. And where is she standing with her academics? Is this something that, we really need to, I think the counselor should be involved with the parents at a meeting to let them know, is this affecting her academics and how are we going to handle getting them to keep it a student parent?
That makes sense. Absolutely.
And also with her seeing her image, that's the age where they're looking at everybody else, and with her disability, a counselor could be beneficial to that. But I think education is the most important, to educate the mother with the recurring UTIs and catheterization and things like that.
Absolutely. Yes, ma'am.
I would like to piggyback on the fact that she's 13 and looking at her image. But I'm also trying to think about where other people is coming from. And why? Is she in a wheelchair? She's in too long. Is she not going to restroom because of how it takes her to go to the restroom because of her image? There's a lot of issues going on here, so the counselor would have to be involved. But then the parent and the doctor would definitely be my first choices.
Okay.
Just to identify where the pupil is coming from and why, and what can we do in school to make things better for her.
Absolutely. I appreciate you bringing that up. I'm going to piggyback on that comment just in a moment.
And you too, and it may be that you need to have an entire meeting with the teachers.
Yes,
and
yes.
everybody so that she can change position, get out of the chair, whatever that needs to be to help with that, to keep an eye, and let her come down to the clinic and clean things up and get back so that everybody's on the same page working with this child.
Absolutely. That's exactly the point that I was trying to illustrate on this case.
And for a 13-year-old, there is absolutely no reason why you wouldn't include her.
Right. Exactly. Very good.
That was my point, is if she complies at school but is not seemingly, what I'm understanding, not necessarily complying well at home, we need to talk with the child and get the child involved in what is the difference between school and home.
Absolutely. And here's the story on her. She didn't want to cath herself in the girls' bathroom. And so involving the school personnel to be able to find a private bathroom for her to use was a key to helping her cath regularly and have fewer UTIs. And her decubiti were from poorly fitting orthoses, ankle-foot orthoses, and a poorly fit wheelchair. And so I applaud you all for coming up with the idea of a multidisciplinary, an interprofessional team meeting to get all the players involved to address all of those different aspects of it. And really the whole issue about calling CPS, that is a pathetic punt. It does not in any way advocate for the child, because you as members of the team are in a position to be able to work with other members to solve this. And trying to have some punitive action against the family is certainly not going to solve it. It will only exacerbate any sort of psychological overlay that's going on here. So I applaud you. Very well done. Ready for the next case? Okay, so teamwork is really the issue, as I said. And just to remind you all, the members of the interprofessional team, you can see a role for each person to help Starla get her health back on track. All right, so meet Eugene. He is 7 years old and he has severe chronic lung disease. And he just recently came to your school, so you don't know him really well. He was born at 24 weeks gestation and developed bronchopulmonary dysplasia, so he's got a lot of scarring of his lungs. And ultimately, he had to have a tracheostomy because of all of that, and he still has his tracheostomy. Well, he's developed respiratory distress, and he needs suctioning, and it seems like he needs some oxygen as well. So how can you best serve Eugene's needs? He's a sort of a high-risk student, at least intermittently he is. So would you think he needs to just stay home? Do you call 911 when he gets in distress? Okay. All right. You know, people do these things. I didn't make this up, I promise. Okay, so again, a couple of minutes, speak amongst yourselves, and then we'll share wisdom like we did with Starla. So who here knows Eugene? Okay, so we've got some people with some experience under their belts. So who would like to offer the first words of wisdom?
First of all, he's a transfer student. That means if he has had all this, he either should have been either 504 or he's an OHI kid, which is other health impairment. That means you've got to have some, should have, information on his transfer. First thing you're going to find out is what information you have, what doctor's orders you have, and what services he has been provided. He may actually be coming with nursing services. Who knows? We don't know because it just says transferred into your school. You know, and who's been performing these services. But something should have come with him. Although we all know these kids show up on our doorsteps, and all we get is this kid withdrew from this school. You know, but the first thing would be is you would have to have staffing. Just to find out, and a meeting with a parent, what are his medical needs? Because we really don't know what all he requires.
Absolutely. How realistic is it to have that sort of staffing meeting?
Very, very.
Okay. Well, yeah. Right. But particularly before an event happens. Like, what if the event happens on day 2?
Not give up. We can't do anything without orders. So if he shows up with no doctor's orders, you do call the mom and say, I cannot do anything without physician orders. So that's for you.
I tell the mom you can't keep him safely at school. You know, it's not safe for him to be at school because I don't have this.
But see, I find the easiest thing to do, and I was just telling her that I'm a new school nurse. I'm a for a couple of years. The easiest thing I found to do was just to ask them when you get those kind of transfers in at the office, call me. And let me come down while the parents are there, and everybody's there, and then I can ask all the questions that I have then, or I can set up a meeting then with the parents and the counselor, because I'm in the office. Who's here, who's not in here? And we need to talk about this because this is what my problem is. And see, I can voice my issues at that time, and I can say, they cannot stay today. I can't address any of this today, right now, because I don't have everything that I need. So you cannot register today. Your child will not be registered. And they complain, and they fuss, and they do all that. But they can't stay today. You know, we'll have to have all of this. So that works really well for me. Now, it doesn't always happen, and I have to scream when it doesn't. Generally, they will call me and say, you know, nurse, can you come next? Nurse, can you come down here? Can you come down here like right now? Yeah. So that works well. And then you can have that little meeting with everybody there, impromptu thing, and set something up a little later.
That's wonderful. Address it proactively before the emergency.
That's, I was just adding on to her point because I'm the life skills nurse at my campus, and we have to have an OR. And at that OR, if they don't have everything medically necessary for that child to come, I can say I will not accept that child for the safety and the advocacy.
That makes a lot of sense. That does. Yes, ma'am?
You were asking us to take answers from A's and B's. None of those are good.
So tell me the ideal circumstance. So you've accepted the patient in, you've set up a meeting, you've gotten the orders.
And amazingly, what you need will come back to you very quickly.
Yeah, absolutely. That makes sense.
You can't legally tell
Absolutely.
I think me and my experience, I just went through a process recently that I had to get private duty nursing for one of my students coming in who had doctor's orders with a home health care company that said that they needed one-on-one nursing care. What I had really had to make sure I did, because this was an experienced mother who has had legal action against our district before for a similar situation. It didn't go anywhere, but really understanding that these parents, back to what you're talking about, the sensitivity to their healthcare needs of their child, this is a chronic condition, making sure to make that we want to provide a safe situation for them and provide that free and appropriate education, but the education is not going to be appropriate if we're worrying about the safety for that child. So
absolutely.
Really making sure we're sensitive to those needs and it actually ends up in a huge gateway and gotten us really far with that one.
Excellent. That's wonderful. Now, if you had this student in the system and you had all the orders and you knew what you needed to do and you had somebody who was in dire straits with regard to respiratory distress, how would you proceed from there? I'm sorry? Who wants to speak? I'm sorry? Mm-hmm. Okay. How do you make that judgment? Mm-hmm. How do you make that judgment if somebody has intermittent distress? How do you make that judgment to call 911 or call the? So. Mm-hmm. Mm-hmm. Do some of you have students that their vital signs really are not within normal limits as a matter of usual? So you sort of, in some regards, you accept that for them as their baseline. And so really it's a matter of using your medical judgment and triaging them based on what you know about their baseline, correct? So.
They want to have parameters from the physician.
Yes.
Now, when is it actually a 911 type of situation?
That's helpful.
Yes. There should be a care plan in place where you know those numbers and when you do this and when you do that.
Absolutely.
Transportation has to be involved in a case like this too, because if the child is at that, the driver may, on the bus, they may need oxygen.
Excellent point. Yes, excellent point. There's a lot to planning for these sorts of patients or students, right? So, okay. And the idea here was really about triage, but you all brought up many more points that really enrich this case a lot. Okay, our third case is a toughie. How many of you all did you say have cared for a student that's terminally ill? Okay, several of you. So this should be an interesting discussion. Let's talk about Alex. Alex is 15 and he has a muscular dystrophy, and he's really declined a lot over the last several years. And now he's in a wheelchair and he's bound, or he's fed through a gastrostomy tube, and he's beginning to have a lot of trouble clearing his respiratory secretions. He doesn't have a real effective cough. Then his mother says that the doctor says he's terminal. In fact, the family is entertaining the possibility of enrolling him in hospice care. So in this situation, how would you proceed? You have somebody who could die at school. Consider these different options and discuss amongst yourselves, and then we'll talk in the big group. All right. So who knows Alex? Would you like to speak first?
Well, actually, it's a friend of mine, grandson, who definitely declined and ended up being in regular ed with me. You had mentioned that they were about to call hospice, is that right? So he was pretty declining at that point.
Correct.
I think it would depend on whether he really enjoyed going to school or did he really want to be home and that felt best for him. So A versus C. A home health nurse, I mean, I think that a quality aide would be probably, as long as there's a nurse in the school all the time, he trains to probably perform things next to him.
Absolutely. That makes sense. Other thoughts?
Back to this is going to be on our, you have to have the full community involved in this. Because what happens if this expires in a regular ed?
Right.
What about
Right.
You know, and what about, you know, doing a little bit of all of it and doing intermittent home health care or homebound teaching? You know, it's just going to have to be an art where everybody gets involved.
Absolutely.
But he may have been in that same school with those kids for a long period of time, and so he may be, they may want it, you know what I'm saying? He may be such a part of the class that, yes, they know over here this is gonna happen, but they don't see class without it. So it all depends on what the setting is too. If he's starting, if he's in a new school, so what? But if he's in the same place he's been, it may be kind of good for them, you know, as long as the counselors are involved with the other students.
That makes a lot of sense. The other thing that I think is worth considering in this situation is really the mode of death. And if you have somebody who has a cardiac condition, who's at risk for a dysrhythmia and sudden death, that's different from somebody who's likely to get pneumonia and end up in the hospital or at home and die that way. So I think considering the time course as well as we can predict it, which sometimes isn't very good, and then also the mode of death will help us make rational decisions about how things are going to go and how the other students will be impacted and that kind of thing. I really do appreciate also acknowledging the student as a really important decision maker in this process. Sometimes we forget about that. So go ahead.
Something else I wanted to mention, I had a student with cancer, and his parents, you know, a lot of times the parents don't know what's available, but they wanted him to be with them. They wanted him home with them to spend time, as much time as possible. And so he was offered homebound services. They had no clue that was available, you know. So we had a meeting and we got that straightened out.
That's wonderful. That's really great. And see, this is where us knowing about what's available and being forthcoming about that can really serve somebody in a way they didn't even know they could ask for. Yes, ma'am?
Well, the part of the scenario got me was that the doctor says he's trying to, did he know?
Did the patient know? You know, I didn't specify in this situation, and that's actually a very relevant point because, you know, when you were saying about the parents, I was wondering if you were going to go there. Parents don't want the child to know. And we encounter that really frequently where the parent doesn't want to talk to the child about it or tell them. So how do you handle that?
I just think this is a time for education. This teaching coping skills not only to the child, but to those that are around him. Because at that point, I mean, if he knows, then maybe he's discussed it with his friends, maybe he has not, maybe his friends are scared by looking at him. We don't know that. But now is an educational moment for the surrounding area of how to treat COVID.
Absolutely true. Was there a comment over here? Yes, ma'am?
I was also going to say, you know, is he hurting? You know, because sometimes if you're in a regular classroom with teenagers that are 15 years old, there's going to be noise. You know, there's going to be a lot of words playing. It's going to affect his, you know, quality, his well-being, you know, his comfort.
Absolutely.
There's just a lot of factors you have to take into consideration.
I agree. What I'm hearing from you all is it's a case-by-case situation. Each individual student, each individual family, the other students in the class, the teacher, the other staff and personnel, all of those things have to be weighed. Now, over here we had a comment earlier about we have to have a meeting with everybody involved. So who's everybody? Who? Okay. It's full-fledged ARD, right? And if indeed the patient chooses to enroll in hospice, then having the hospice personnel available can be tremendously helpful because if he should decide to stay in school and like Deb said, his classmates want him there, then a lot of times hospice personnel can really do a lot to help counsel others that around the dying individual to be prepared for it. So that's really great. Any other points that you would like to make about Eugene? I mean, Alex?
It's terminal, and I don't know the family. Sometimes you resuscitate or if he was in school.
Absolutely. That is a very, very important point. The out-of-hospital do not resuscitate order. So.
Our district will not allow that. If the student, they won't allow a DNR at the school. Because they think that issue has been addressed.
Interesting. Is that the case for other schools?
Yeah, you have to make sure the DNR is a legal.
Yes.
You need to actually see it. It has to be kept with the child at all times. Because if that child, if something happened to the child while at school, EMS is still called.
Right.
They have to see the DNR order. They remain with the child. There has to be a plan in place on your campus and it has to be approved through your district as to what steps you're going to take if this does occur on your campus.
Yes.
Who all is going to be involved, who's going to respond, who calls who, where will the body stay, who's picking up the body. All of those things it has to be a written plan in place.
So her question, when you made the comment that your district doesn't allow it, we wonder if that's legal or not. Does that appear that would be legal, that a district could say, we're not going to take a DNR?
I'm not familiar with the law on that. I hadn't heard that before, so.
Department in my district, no, will not
honor that? Interesting. Okay. Thank you for your, oh, yes, ma'am.
I think they're saying the same thing, in that you have the out-of-hospital DNR, and you accept it, but you implement all measures to maintain, to sustain life until EMS arrives. And the DNR.
Yeah. I don't know. I hadn't heard of that before, but that would be interesting to explore. It would. Thank you for bringing that up. So I think through all of these cases, planning ahead is of the essence, right? And communication is so very important. And when you're dealing with the situation of a dying child, communication is even more important, of course. So really, in summary, we're all members of the team, all of us, including the students. And we do work collaboratively and have a plan of action, and you all have articulated that very nicely. And we communicate with one another to optimize care. So are there any other words of wisdom, any outstanding experiences that you would like to share with the group here? Something gone very well or something gone very wrong that you maybe learned about that you'd like to share?
The only thing I've learned in my years working in the school district is that I think it's real important to have staffing. When you have a child like this coming to your school, that you as a group can talk about everything, look at the orders that you have, look at the whole picture before you sit down in an ARD with the parents and try to do their IEP. Because a lot of things can be taken care of ahead of time where you can sit in an ARD and I'm going to say it, you'll look like an idiot because you can't answer the parent and give them the information that they need because everybody's kind of going, well, I don't know, I guess we'll have to check into that and all, so I think that staffing is really important before you have an ARD with people.
That makes a lot of sense.
And it really does make the ARDs go so much better when you've got everything laid out.
And even in the context of our conversation today, several issues arose that I hadn't thought of. And even if you're smart and experienced and you've been around a long time, sometimes somebody can say something, and as you said, you can make, do the research and make some preliminary decisions before presenting to the family. Yes, ma'am?
Every year at the end of the year, we're supposed to fill out an evaluation. I always comment, I think the nurses need to be involved in any ARD that involves something medical, and I have yet to be informed about an ARD.
Wow. Yeah, Deb is saying that she attends ARDS all the time and the nurse is never involved. I wonder if it would be helpful to ask the parents to specifically request your inclusion. Because as you all said with the first case, you know, you really want to be there and provide for the needs of the child specifically, and that is a motivator for families to get you all involved.
The new SHARS, because if your district participates in SHARS, which is a Medicaid billing, third-party billing, man, they want those nurses there because they can't bill for anything that's not written up in the ARDS.
Very helpful.
If you know the secretary of your special ed department who sends out the notices for the ARDS, just give her a call and ask if your name be on the list, and it comes out in the distribution and get it on your email.
So did you all hear that? Did y'all hear that piece of advice? To ask the secretary to add you to the distribution list? So, yes ma'am? For ARDS.
Something I wanted to mention, I've been working with special populations for several years now, and I really have a hard time convincing the parents that I want to partner with them. I always end up on the opposite side of the table, and no matter what I do, and it's so disheartening because I want to be their partner. I want to be an advocate for their child, and at least 75% of the time I'm not. Yeah.
That's very difficult. Is that the experience? Yeah. Yeah, don't give up. That's really why I put some of those slides in there about grief and facing adversity, because we have a really, really hard job. I mean, it's hard enough to partner with somebody who's raising a normal child, but we're really on the hot seat when we're partnering with somebody with a child with special needs. So is that the experience of some of you?
I feel like there's a lot of the newer parents, 3-4-year-olds that come in, they get overwhelmed. I don't know if they feel like they're intruding or it's just overwhelming, I guess, because they do get phone calls from the different teams, and I just feel like sometimes they just feel like, oh, now why are you calling me?
That's hard. Well, let me just give all of you a shout out, okay? You are doing something really, really hard, but you're doing something very important. You're contributing to the universe in a meaningful way. And so please don't let that get you down. Just arm yourself with knowledge and resources and really bolster one another up, because you're doing the right thing helping these children. You really are. I applaud you. So thank you very much. Y'all go have a break.